And before I introduce the speakers, I just want to thank Barry and Marcia, our clinical working group co-chairs, for doing the heavy lifting on getting these Integrative Clinic webinars started. This is our second one, and a lot of planning went into it, and we have other members of the group as well. So thank you to everyone who participated in getting these started, and especially Barry and Marcia for all the time you spent in laying the groundwork. Thank you. And now I would like to introduce our speakers. We have Melissa Kimura and Sean Guinan, and they'll tell you a little bit more about themselves and their clinics. And I had sent out the PowerPoint slides beforehand, so many of you who took a look at them saw that there are pages and pages of questions, and these questions have been generated by the clinical working group members over the years and just sort of added to our list. And several clinical and education working group members sent in questions that they would like to have addressed. They sent that in prior to this call, and our panelists have looked at all the questions, including the ones that were sent in by our members. So thank you for sending them in, and thank you to our panelists for preparing for this. And they will do their best to address as many questions as possible. They've put together some of their own slides, and I thank them for that. And this PowerPoint deck with all the questions, along with each of their PowerPoint slides, which are guiding their conversation today, will be made available on the website. And how it's going to work is Melissa will begin by talking about integrative practice units and care pathways, and then Sean will talk about practitioner collaboration and patient education in private practice. So that being said, I'll turn it over to Melissa, and here we go. Also do the slideshow. Oh,
do you want to?
Yes, I just remembered that, Melissa. Melissa is going to control her own slide deck, so we're going to change presenters. And now it's over to Melissa, and we'll be able to see her screen with the slides on it. Perfect.
Can you guys see them?
Yep. And on the left, just to let you know, we see SCU Health System, and on the right, we see the next slide, which has a map and a health reform, which is totally fine. Just want to let you know what we see.
Now do you just see the presentation?
Yes, now we just see SCU Health System, the value agenda.
Okay, great. Thank you so much. So anyways, actually I know quite a few of the people in some of the working groups. So hello to all of you that I know, and hello to those that I don't, and thank you for having me here. Beth had asked me just to say a couple words about myself. So again, my name is Melissa Kimura. I'm a licensed chiropractor and acupuncturist and a certified chiropractic sports physician. I've been at SCU since 2008. I was part-time in the beginning because I was also in a private practice in Marina del Rey, which was an interdisciplinary clinic with about, at that time, 25 MDs and 4 chiropractors and me, and a sports psychologist. And now I'm full-time at SCU in the capacity of Vice President for our health service offerings, as well as the Chief Clinical Officer. And I do work right at that intersection of clinical practice and education, so the work that you all are doing is very near and dear to my heart. And let's see, I attended my first ACAC, what was then ACAC meeting back in 2012, so I've sort of been involved with this group on the periphery, but never in the capacity or to the extent that you all are. So anyways, that's me. So what I really wanted to do was just share a little bit of the big picture context around the concept of integrated practice units and care pathways, because I think that this will help address a lot of the questions and maybe lead to a more focused conversation afterwards. But a lot of the questions that were posed by the 2 working groups are things that we wrestle with all the time at SCU. And so I've been trying to work with my team to synthesize all of these things into one all-encompassing approach to how we go about providing integrative care in our clinical settings. So basically, this is a presentation, and one thing that people asked about is how do you get the different providers together and dialoguing. One thing that we instituted a couple years ago now, maybe it's been almost 3 years, is weekly integrative rounds, which are held at 7:30 a.m. before the clinic opens, and it's a time where we have all of the providers together as well as students, and usually it's in the format of a case discussion where I assign a different department to just share any case, and the parameters are, it needs to be a case that you've seen, and then you need to pick someone from another department or discipline to jointly present with you, even if you didn't actually manage the case together, to collaborate on how both disciplines would approach this case, or hopefully it is a case that you did co-manage together and present how that went forward. We had a new term start in January, and then so just to remind the clinicians of some of these big picture things of why we're doing what we're doing, that's why I had this presentation handy. And yesterday when we were talking, I said, oh, I think that this might be helpful to show. So anyways, but weekly rounds, one thing that we do to get providers talking and discussing clinical cases and learning about and from each other. So going into this, the first few slides are really just setting the stage of that we spend a lot on healthcare and we don't get very good results. You guys know all that. So what do we need to do? The triple aim: improve the patient experience, reduce costs, and have better outcomes. The problem that we face a lot, and I think that really affects the disciplines that we represent, are that the behaviors that are incentivized in the current system, that's primarily fee-for-service, especially still in California, highly reimbursed procedures, which our disciplines are not, high volume, which sometimes gets us into trouble, and with insurance companies really not wanting to spend money until they absolutely must. So these are what have been termed as perverse incentives, because they lead to basically putting costs off from insurers to doctors, doctors to patients, and basically all these kind of bad things that make us not have a well-functioning healthcare system. But what do we value as providers? Health, prevention, outcomes, and function. So this all goes back to value. Value, again, is outcomes modified by cost. And then there's this really great article that I would highly recommend to everyone that talks about how providers must lead the way in making value the overarching goal. And this is by two faculty of Harvard Business School. And the article specifically, The Strategy That Will Fix Healthcare, they outline how we're going to accomplish this. And I'll go through that kind of briefly. But basically, we're talking about going from this old way of thinking about what do I have, what are my skills, facilities, resources, and how do I apply these to patients. And I would take this one step further in the context of some of the questions again. How do we know, some of the questions are like, how do we know who should be seeing a patient, or how do we know like patient choice, which provider should a patient be seeing? I think some of those questions become easier to answer once we can get away from this old way of thinking. And as an example, SCU, we were guilty of this ourselves because we really set up clinicians based on our training programs, which really is not patient-centric at all. That was to serve a purpose of educating students. And then we were saying, well, we have chiropractic. Okay, now we're adding acupuncture. So now we have acupuncturists in the clinic. Then we had massage therapists. Then we added Ayurveda, all because of our training programs, which is not a bad thing, but it's just not a really, I don't think it's thinking in that really value-oriented way of, we were basically saying, these are the things that we have, now let's give them to people. And then another example of this would be the one true tool. Like if I'm a chiropractor and I'm wanting to adjust everything, or if I'm an acupuncturist and I'm wanting to put a needle in things, this is the old way of thinking that there's this one true thing that can help. And then, the silos, old way of thinking, So yes, let's transition to a new way, which involves breaking this down and collaborating, or taking a step back and looking at what does this patient and their family need and what they want, or how can we support this patient and their family in health creation? What skills do they need, what facilities do they need, and what resources do they need, and deliver these to them rather than the approach of this is what we have, so this is what we're going to give them. It's a whole different way of thinking about it, which I think makes the case of the integrative health professions much stronger that way, because these are things that people need and want. So then going back to that Porter article, here's his value agenda, and it starts here with organizing into integrated practice units. So basically he's talking about the same type of thing. These are pictures that my colleague Rob Russell took. This is Porter right here presenting about this topic. But the existing model is we organize by specialty and service, which is exactly what we were guilty of at SCU as well. But really, what we want to be doing is organizing around conditions. So the first practice unit that we started at SCU was spine care. And so for a patient who has a spine-related disorder, then we asked ourselves, what providers are most needed to take care of that patient, to help them from a holistic approach and organize that way. So basically, the way that it looks is we have 3 sort of practice units at SCU with plans to add a 4th, and we've taken people and basically said we're going to organize you around a patient with of a specific demographic population, such as for quality aging, or for a specific condition such as spine, and then figure out what providers does it make the most sense to have servicing patients in that way. So that we have the patient in the middle, the different disciplines, and then we have the specific centers for taking care of patients of those conditions. Next step, he talks about measure cost and outcomes for every patient. And then moving to bundled care. So part of the way that we're trying to do this, measuring the costs and outcomes for every patient, is that this is kind of getting to the whole payment question issue. We do a lot of fee-for-service in our clinic right now, but the problem is a lot of things that are beneficial to patients are not currently covered, and I know everyone must be struggling with the same thing. So one of the things that I'm really trying to do is be very deliberate about measuring costs and outcomes, including in a pilot study we have going on relating to spine at Dartmouth College right now, so that we can actually collect this evidence about the clinical outcomes, the costs involved, and the patient satisfaction, so that we can demonstrate, hey, when you approach something in this way, which may involve providing services that aren't normally reimbursed through fee-for-service, when we provide this whole package of care according to our care pathway, which I'll get to later, then actually the outcomes are better, it ended up costing less, and the patients feel happier about it, and therefore showing the value. So that's kind of like a long-term goal that I have, as far as then being able to take that data and going to payers to say, this is what the data is showing. Now can we talk about moving to bundled payments for cycles of care, which is the next step, which could include us being able to be reimbursed for taking more time to do a nutritional consultation with a patient, or having them see an Ayurveda provider, or things along those lines. So here, these are slides, I believe Beth or Jennifer will be sending them out so you can take a look in more detail, but this is just talking about the difference between capitation and bundled payment. There was also, I think last summer, another article in Harvard Business Review that's people debating about capitation versus bundled payment, which is very interesting because I think these are going to be important for the futures of our professions. Side note. And then integrating the care across facilities. So this is where the care pathways come in. Basically, what we're trying to do is make it so that we have care pathways which are based on the best available evidence for whatever condition. Spine is the first one that we did, and that is the one that we have most developed, and basically make it so that all providers are trained to basically operate in a very similar way, so that, number one, there's not a black box approach feeling from the outside. So, any other provider who's sending to our spine care clinic knows the basic path that we're going to be taking and what clinical findings might determine a different course versus, another course. So here's just a more of like a look into what some of it looks like as far as low back pain and neck pain are concerned. We have these steps here where we're saying, is this our patient? We're always screening for psychosocial obstacles so that we can address those while treating, because there's been a lot of evidence showing that these can really impact patient outcomes. And then we actually will match up our treatment based on the likely diagnosis, so that not every patient who's coming in is always getting chiropractic, even though the chiropractor might be the initial point of contact. So basically we're trying to match the treatment to the condition in a more honed way than has been done in the past. So same thing, we can do these for neck pain, back pain, headache, obesity, other conditions as well. That's the whole care pathway model, which really speaks to helping the patient to know what provider it's going to make the most sense for them to see at any given time, and sort of answer those questions so that everyone is on the same page about it. And then the final step in the Porter model is building and enabling information technology platform. That was another question about what platform do people use. We use one called Visual Outcomes, which originated in Australia, and it was designed by a woman who's a DC, LAC, ND, and something else. She has another license too. But it was really specifically to put the patient at the center and to be flexible to use in an educational setting, as well as with a lot of different provider types. So they now have it set up in some medical clinics in the U.S., as well as at SCU and a couple of other locations too. So I'm happy to talk to anyone about the EHR as well. So anyways, those are my slides. Sorry, I think I took too much time there, but I may pass control back to.
All right, Melissa, that was fantastic, and I was going to interrupt you in another minute or so, saying I'm sorry, but could you wrap up? That was great. You packed a lot in a very short time, so great job. And now I will pull up Sean's slides. So Sean, I'll put it in slideshow mode too, so we can see the whole screen. There you go.
Perfect. Thank you, Beth, and thanks everybody for from joining in. Can you all hear me okay?
Yes, you sound great. Thanks.
Perfect. So I'll just do a little mini introduction as Melissa did as well, to let you know who I am. So my name is Sean Guinan. I'm a pediatric and adult acupuncturist, and I work at a clinic in Kingston, Washington, Kingston Crossing Wellness. For all of you that are unfamiliar with this area, it's a population of about 2,000, so it's quite small, sort of small town feel. We treat a lot of rural or semi-rural population, although we are just a hop, skip, and a jump away from the larger Seattle area as well too. We are, despite being a small population, a high-volume integrative medicine clinic. What I mean by high volume is typically on average about 100 patients a day walk through our doors. We're a 5,000 square foot center with multiple practitioners underneath one roof. So there are 3 chiropractors, 2 acupuncturists, 1 ND, so naturopathic doctor. We have a ARNP as well, NMA, 5 or 6 actually massage therapists now as well. And then a whole complete staffing, office manager, front desk folks, marketing manager, and the rest, right? So there's a lot going on under one roof in a small town, and we are able to serve a lot of people, which is fantastic. Our focus primarily is chronic pain, although the nature of a private practice model in a small town is that we do practice family medicine as well too. So we treat all ages and multiple conditions, although many people that come through the door to us are coming in for chronic pain. Okay, so just to kind of give you the lay of the land in terms of where we're coming from. In terms of what I'll be talking about today then will be practitioner collaboration and patient education, specifically in a model like this. Ultimately, how does integrative medicine look, or how can it look in the context of a small business, ultimately, right? And so there are a number of barriers, as I'm sure you are all aware of. That's perfect, Beth, on that slide. That's great. Thank you. To implementing a model like this. Financial barriers, as I'm sure you're all aware, things from billing, making a profit, sort of leaking money in a center this size that is still a small business, right? That needs to be kind of oversight there. Ethical considerations, things from overtreating, cash versus insurance services and the rest. Basic logistical formalities of patient flow. How do you get one patient from one provider to another, and then back out the door and then back in the door for future care. And communication is a big one, which we'll spend some time with here in a quick minute talking about. Communication at multiple levels within a business structure like this. Documentation, electronic health records, and then of course the legal side of things too, making sure we're OSHA compliant, HIPAA compliant, contracts with providers, and all the rest of it, okay? Next slide there, please, Beth, if you don't mind. So if we jump right into this notion of, what does it take ultimately for a model like this to be successful, and one of the key pieces is that practitioners need to collaborate, right? And that sounds very simple perhaps on the surface, but bringing this into action, of course, has some challenges. So what I want to talk about briefly is just what are the key elements of practitioners being able to successfully collaborate. And what I found, trial by fire to a degree, is that it takes three things. One is communication, the other is knowledge, and the third is respect. So I'll talk about real quickly what each of those looks like. Next slide, please. So under knowledge, what we have to think about is that from a provider's perspective, and we'll get into the patient's perspective in a moment, because of course that's central to everything that we're doing, and as Melissa said, that patient-centered focus is where we're going. But on the provider side, providers do need to be knowledgeable about various modalities when you're in a small business like this. So what that means is that although I may practice acupuncture and East Asian medicine, I do need to have an understanding, a very basic understanding on what even chiropractic is, what naturopathic medicine is, how massage therapists can help a patient, right? And then, of course, how to communicate that as well to patients. So knowing the basics of what the other providers are doing and what they're capable of doing is really essential. We help mitigate this by every new provider that we bring on to touch base with the additional providers that are in-house, so that we can explain our services to that provider, and also so that we can share with them how we explain our services to the patients and really the value of those services. Patients themselves seem to care very little about exactly what it is that we're doing. They just want to know how it can help them, right? They want to know where that value is. And so we want to be able to communicate that to other providers. We also want to know what practitioners have the most success with as well too, and that kind of goes under that knowledge piece a bit as well there, in the sense where although you may as an acupuncturist be able to treat a number of conditions, just as an example, there may be some that acupuncturist is more successful with, and we do need to be able to have everyone know about that. Next slide, please. The second piece also sounds fairly rudimentary, but is equally essential, and that is just basic respect, right? As providers, we tend to get, if we're not in an integrative model, sort of tunnel vision to a degree about the value of our particular service or craft and how that can assist a community or a patient base, right? And really, the first step of respect is trust. Right. So coming into this, I know some folks had a question about hiring other practitioners and the complications of that, or challenges rather of that. Really, the providers need to have a trust for other modalities as the building block then of respect. Also, what's key underneath respect is to be able to reduce or eliminate competition among providers and instead promote cooperation. And there are certain strategies around that. Some on the financial side are just as simple as making employees salaried rather than more of an independent contractor model where they're paid per patient. In a sense, it levels the playing field then, so they're willing to share, so to speak. And we can talk about that more if people are interested in that. The last piece really of respect is taking this broader perspective and seeing outside of the box of their own modality, right? And as I mentioned, that involves first having the knowledge base, really the knowledge base to do that. So next slide, please. The third element here of the practitioner collaboration piece is also communication, and this is so key, right? This is communicating among providers. So we also do have weekly meetings, provider meetings, where we get together and kind of have our own structure, a little different than what Melissa mentioned in her rounds. But nonetheless, we're able to open lines of communication with providers to talk about patient cases. Maybe that's sort of troubling or challenging cases, or maybe that's just like, hey, I really got to pick someone's brain on this, right? And so we make weekly time to be able to do that. We also communicate amongst staff, so we have staff and provider meetings as well, so we're making sure that the message, the face of the clinic, and what that is communicating out into the community is really accurate and appropriate. So we have a couple of weekly meetings, really. And then this really transitions us into communicating with patients, which is really the key to all of this, okay? We also, as providers and as the staff in an office like this, need to be able to communicate the what, the when, the why of how we're saying things and what message is really carrying across to the patient base. So next slide, please. When we talk about patient education, then this in the kind of traditional model right now is, as many patients that come to us who are new to an integrative model, they're sort of blown away in the sense where to get all multiple services under one roof is unfamiliar, right? It's uncharted territory. They're used to coming at it from the depiction that's on this slide here, for example, where a patient's sort of isolated. They're out on their own. There's maybe seeing, they're absolutely, generally speaking, seeing a primary care provider. Maybe they've had referral to other MDs or DOs. They might have an acupuncturist or have had an acupuncturist experience at some point in time. They may have seen a chiropractor, an ND, or a massage therapist or whatever, but it's very disjointed, right? This current dominant paradigm is super segmented, as I'm sure you all know. So the patient has multiple providers, but really no cohesiveness of care. Therefore, they're coming in largely uneducated, and I put that in air quotes, not that you can see that, but know that that's in air quotes, about what modalities do what and why. Okay. As a result, there's no continuity of care for the patient, or very limited continuity of care, and there's also no one providing oversight to them. Maybe they're on multiple medications, have had multiple procedures, they don't really know what their next steps are, and they're very much confused. So this not only increases the risk of medical error, but really it just promotes a lack of communication then as well among the providers, and so the patient isn't getting the best care possible. Okay. Next slide, please. And so what we're trying to do, what we're attempting to do here, and this clinic is about, we're a decade in right now, is sort of switch this paradigm, okay? And transitioning to more of a nested kind of model of integrative medicine in a private practice business. In that, the patient can have a cohesiveness of care, the patient flow works for the patient, and also that the patient receives better outcomes for both themselves really and their family, because a person is not disjointed from their family and certainly not from their community. What we see then in this model is in the center is very much the patient, right? This is focus. They're coming in, they have a need, they have a pain, they are suffering, okay? And that dictates the care that then they receive. Rather than, this is the modality we have, over here, this is another modality we have over here. It's like, no, what is the patient's need? What is their focus? And then how can we best serve them? The second layer then is that they do have a primary provider, so to speak. So a point person that is a provider that largely manages their care. Outside of that, we have this third layer that they're nested in, which is the additional providers that are providing their own modality or services in the best interest of that patient, all coordinated largely by what I'm just terming here for our needs, the central command. This, in our case, is our office manager or one of the doctors in our office that ensures that patient flow is happening, that is overseeing the bulk of their care, making sure the financial piece is taken care of as well, so the patient really feels supported, feels heard, respected, and valued, which is largely lacking from their pre-existing experience in the medical world. Next slide, please. To give you an example of what this flow looks like then in kind of to give you the rundown on it, here's just a case example. Say we have a woman, 54-year-old woman coming to us. Often there's comorbidities here, right? So fibromyalgia, presenting with also a history of migraines, say for about 10 years. So the clinic entry point for her may have been a Facebook ad campaign, okay? We've been having a lot of success with Facebook ads in terms of the marketing side of things. That lets them know that we are here. We are not advertising, hey, come in for acupuncture. We're not advertising, hey, come in for chiropractic or for a consult with an ND. Instead, we're marketing for their condition. So say, for example, migraines here. Their point of contact coming into the clinic may be chiropractic, just again for the sense of our purposes here. They have their initial visit there. During that initial process, we do an ROF, a report of findings with them, to let them know, hey, this is what we're seeing. Maybe we've done some imaging on them. We can do x-rays and ultrasounds here. We may refer them out for MRIs if it's warranted. Go over some of those findings, let them know, hey, we're also going to refer you over to talk with our acupuncturist. Maybe we'll have you visit with our ND as well to do a workup with them, and maybe possibly massage could be a benefit to you. It's completely laid out for the patient. It is communicated to the patient how exactly it is that we can help them. Then in follow visit, they will have a financial plan overview so that they don't feel like they're being snowballed. We're very clear and transparent from the very beginning with patients that, hey, this is what is covered by insurance and this is what's not. This is what we suspect will be your financial responsibility. And then we develop financial plans for patients that need those as well so that they can get the care that they need. Then they will get a mix of care, again, with one provider being a primary point of contact and the additional providers providing ancillary care. We often do, especially in many cases with folks with chronic pain, refer them out because we do not have a psychotherapist, even emotional freedom technique, other modalities there. But there is a psychosocial component we find, significantly so, in folks who've been in pain for a while, and we just get better outcomes when they do see a mental health counselor. Then we reevaluate on a monthly basis, so it's 30 days or more, and that's built into our system, our scheduling system, so we know when those appointments are. We go over the patient, what the changes we've seen so far, what we anticipate in terms of moving forward from here as well. Again, that reassessment is done with the primary provider. Then in terms of continuity, again, as I mentioned, we have weekly meetings with care providers so we can discuss the patient cases, make sure that the patient isn't having to repeat themselves 1.5 million times. Instead, we are communicating with each other to streamline their care. And then eventually, when they're example, pain is largely under control here. Maybe their migraines, they're having a migraine once every 6 months rather than 4 times a month. Then we maybe transition them to more of a maintenance or preventative care. And that's when we have that conversation with a patient around exactly what it means to practice preventative medicine as well, which is new for many of them. Last slide, please. And so how do we make this all work? I mean, basically we have systems in place, right? A small business needs to always have systems in order to be efficient for one. Everything from the front desk to the back end and everything in between, okay? We also, as I mentioned, remove provider competition as much as possible so that providers are excited to refer their patient to a modality that they think would amplify their care. Okay. Also, we have the central command, as I mentioned, so the overarching view, the 10,000 square foot view of the patient's experience from start to finish in a clinic. Patient engagement as well is key, educating the patient along the whole way, knowing that they are completely unfamiliar largely with our services, with what we do and the value of them, so communicating the value of the services to the patient continually. Also transparent business practices, really clear about the expectations of care from the beginning. Are they going to be pain-free? Maybe, maybe not, right? And just being clear about that. How much is it going to cost them so they know what they're getting themselves into? And then the last piece I'll say is what I I view as mesh networking, creating a web of referrals, a lot of in-house referrals happen here. I know some of you had questions about that. Again, that is essential for a business like this to succeed, as well as external referrals, maybe to psychotherapists, MDs in the communities, PTs, OTs, everybody, right? So we do have sort of a big web of a community supporting them or rallying around a patient and their care. I hope that gives you at least a little bit of a sense, I know I speak fast, so I apologize, around how this model can be applied, one application of it anyhow, within the private practice model.
Well, fantastic. But both Sean and Melissa were really great at speaking fast and clearly. We're really packing a lot of information in here. I'll go back to our first slides, and this is the time for anybody on the webinar to type a question that you might have for either or both of our panelists, a question or a comment, into the question box, and then Jennifer will monitor those and let us know what she's seeing.
While you guys are harvesting the questions, if it's okay, I just wanted to, I thought, Sean, you really hit on some key points. The employees being salaried, I totally agree that that is the way to go, because you don't want to, again, this, I think it speaks to incentives, and having people incentivized through salary and how they're paid to work together is really, really important. If like one thing that I'm looking at doing right now is also incentivizing across the practice unit, so everyone is salaried but eligible for a bonus if their practice unit hits certain targets or goals, which also involve quality measures, not just revenue. Hiring for attitude, really, really important, because you're not going to take someone who's not willing to work with other people and change them somehow. That, you know, I think is really key. And then the thing that you were saying about the meetings, we have the clinical rounds every Wednesday, but we also have more like a business meeting at once a week on Thursdays with all the providers, which is kind of something that happened organically, because this is like where we have to discuss just more of the business nitty-gritty scheduling and things like that. But usually the last thing anyone wants on a university campus is another meeting. However, this is a meeting that people have requested to be able to come to, because it's a really great way of sort of working out the details of related to clinical practice.
That was great. Thank you, Melissa. Jennifer, do we have any questions coming in, or shall we go to the questions that were sent in?
Let's start with some of the questions we have sent in.
Okay, and these are basically in order that I received the questions. So we have a question from Dale about what are some of the processes incorporated at your clinic to facilitate collaboration among providers, and how does the sense of collaboration support referrals? So is there anything in addition to what you've already covered that you would want to add to address that question?
Other things that have worked well for us are basically encouraging, well, we do it with students, is having them rotate with people from other professions. So same thing with the clinicians, to either be a patient to experience the other practice types, or to observe someone else giving care, so you can, like Sean said, see how an acupuncturist might do a report of findings from a TCM standpoint to a patient and come to a better understanding of that, or even on a, rotating with a surgeon to see sort of what the gamut of surgical options for a specific condition might be. We're not asking them to be a surgical patient, but that's more for like Ayurveda, acupuncture, chiropractic, things like that. And then the other thing is we set up in our electronic health records a form that's specifically used for inner practice referrals from one provider to another, as like kind of just a little note saying, hey, I'm referring this patient from chiropractic to acupuncture because of X, Y, and Z. So that way it sort of clues in the person being referred to about why, and any like key notes or test results to review. Just because that was something that was identified of a need for people to just be able to quickly say, hey, take a look at this, this, and this. so that they have more information around the referral.
If that form is something that you can share, would you send it to me and I'll make it available to some of the call? That'd be great.
Sure.
Thank you.
And we also use, just to add an additional piece into this, in terms of collaboration among providers, we use an internal messaging system as well too, so we can quickly communicate with each other should the need arise, for example, and we use this every day. Hey, I've got this patient.
We have that built into ours, and no one I'm like, why don't we use this?
Oh,
it's built in. Why don't we use this? No one uses it.
The most efficient thing ever, because I can send a quick note to the naturopathic doctor and say, hey, do you have a minute for a quick consult? Sure do. Come on in. Here's the baseline. So then she knows that already when I walk in the door. Hey, I've got patient so-and-so. Let's have you two meet up. And it really streamlines things and makes things great. And as you mentioned, Melissa, too, what we do offer all of our staff here as well, too, is unlimited access to services as well, so that they can have that experience of what acupuncture is, of what chiropractic is, massage, and all the rest of it. So then they can better communicate that as well to the community of people who are walking in the front door, remembering that the front desk is the face of the clinic, right? And so if they have that personal experience, that really allows for greater collaboration in the end amongst everyone else too.
Yeah, great. I'm going to tell my providers that you said about the messaging to try to motivate them.
Please do give it. Yes, works wonders.
Jennifer, I see that there is a question that came in. So before we get to that, let's have one more that was sent in advance, because Garrett is on the phone, and then we'll get to a question that Steve just typed in. So the second question is about hiring, and do you have anything more to say about finding the right candidate?
I'll add if that's okay, Melissa. Okay.
Yeah,
it's tricky. I'll be honest. It's tricky.
Yes, it is.
It is a challenging area. We it's like trying to get a read on folks. We have multiple interviews for one. Okay, so for aspects of it, there's individual interviews. There's also group interviews that they'll go through. If it's appropriate, we may also have a potential candidate shadow another provider as well too for half a day or so. We also do a 30-day kind of trial period hire for providers, which is basically gives both of us an easy out should that need arise with no harm or foul, But it is really, we try and be as clear as we can in our position descriptions and in our hiring practices around the expectations, that this isn't just you coming in doing your solo thing, that this really is a team. And more importantly, to be quite frank, we also view it as a family of sorts, right? And which comes with its own dynamics. But really we are a tightly knit group of providers and staff, and so it absolutely needs to be the right fit, and it is truly challenging. Yeah.
And the only other thing I would add would be potentially like networking at certain conferences that attract a lot of like-minded people, like AIHM or even any of the ACIH conferences. Those can be good places too.
Great. I'd like to get to as many of the questions that were sent in as possible, since people took the time to send them in. We do have one that came up on the questioning. So Jennifer, do you want to relay that one?
Sure, Beth. This one pertains to financial costs, and the question is, the panelists could talk about the financial costs for patients when they're seeking treatment in a collaborative care environment, and is it offset by insurance grants, et cetera. And I would actually tack on one question too about financial stability, sustainability of the clinic and the practice. If the panelists would speak to that, that would be fabulous.
Basically, at SCU, it sounds like it might be similar to in Sean's situation, which is the same as when I was in private practice, is that you have your services that are covered by insurance, which, we have some medical services that are chiropractic and acupuncture are, and then you have those that aren't, which are like most ND services are not covered in California, and Ayurveda is not covered, and massage therapy is not covered, as an example. So we do have, it is an access to care issue, in my opinion. because some patients can afford to pay cash for those services and other patients can't. Or if someone has insurance that covers acupuncture, but then the fine print says only if used in lieu of anesthesia for surgery, then those patients need to pay cash for the services too. So yeah, it's not great because some people can't afford it, and you can only give away so much free care and still stay in business.
Yeah, it absolutely. I would echo those sentiments as well, too, Melissa, in that it is an obstacle to care. What I will say about where I practice, which is a little different than where Melissa is that we're in Washington State here. This is a very insurance-friendly state for holistic healthcare providers, by and large, in the sense where most people that come in the door, as an example for acupuncture, and I just give that as a reflection because I'm an acupuncturist, does have some degree of coverage. Maybe that's 12 visits annually, maybe that's 20 visits annually, or whatever. Their copay, of course, will vary. Coinsurance is a thing, and then it's a matter of whether we're in or out of network, right? So even when patients do come in and they're like, great, I have acupuncture benefits, what are those benefits? And the specifics of that is really just made to be utterly confusing to the patient. So we help them break that down. We have not only a full-time medical biller in office, but a part-time medical biller who works from home as well. But then one of our front desk staff members, she does all insurance verification as well too. So by the time the patient leaves their first visit, if she can access that information either off of the insurance company's website or calling in to get that information, then a patient at least has a rough breakdown on what the expectation would be there, how many visits there. Knowing that even, for example, on the acupuncture side, if they have 12 visits annually, I may, though, be recommending 18 to 20, sometimes even more, depending on their condition. So then, even though, yes, they'll max on those benefits, they'd have to pay for the additional services above and beyond that. We try and make that accessible to patients by developing comprehensive care plans for them, or CCPs is what we call them, meaning any value above that we can break down into monthly payments for them. They may even be able to use care credit for it, which is credit-based basically loan for services, should they need that. Most people don't use that, but we do have it there. And then, we're also a DME approved center as well too, durable medical equipment. So for folks coming with Medicare, they can access that too. So they can get a back brace, they can get a knee, knee brace as well too, or a TENS unit, and it's covered by their insurance. So we try and do our part to figure out exactly what insurance coverage they have, so that way we can, again, let the patient know, hey, this is what will be out of your pocket. This is what insurance, it seems now, will cover as well too. But there is always that gap, that patient gap, where people fall through and they do then cover the bulk of their services financially.
And I think the financial reality of it, while we're still in the fee-for-service world, is you have some services or things like DME that are more highly reimbursed. So then you can kind of leverage, as long as you have some of those kind of business, then you're able to be more generous with, ability to pay type of patients on that end. But it's like you do have to have money coming in from somewhere to offset anything you're giving away somewhere else. Or you can set up a practice in a very affluent part of town and just, you don't have to worry about it, cash insurance only. But
and that is very, very true, and it's part of the reality. We offset that. And I think it was Jennifer who mentioned the financial stability side of it too, around having some services that are cash only. For example, we have a comprehensive weight loss program. Insurance isn't going to cover that, so a patient knows if they're going to come in, and that could be anywhere from a $1,500 to $3,000 program per patient, right? And so if they're willing to pay that for this comprehensive program, then they're paying that in cash. We're circumventing insurance, and then that gives us a little more financial stability. Same with the cosmetic acupuncture program we just launched and all the rest of it, right? So some of those cash-based services for the people who can afford them and value them, because that's their pain point, that's what they need, right? Then that really allows us to have greater financial stability over the long term.
Yeah, I'd say so we started doing joint rejuvenation for that reason, because that's cash. And the financial reality is, in order to stay in business, you need to do some of these things, which are, I'm not saying they're not valuable services, they're totally valuable services. They're just cash and they're well reimbursed, so that you're able to do some of the other things too. But this is why I'm also really curious about looking for the bundled payment and other kinds of ways of paying for things and demonstrating value, which we're able to do as a university, which, not something that really private practice would set out to do, so that we can shift it for the future so that it becomes a different type of conversation, hopefully.
Yeah, hopefully. Yeah.
You guys are doing a fabulous job of answering all these so quickly. Let's try, we have 2 minutes left. Let's try to get in one more question, and then if the panelists are willing, I will send the questions that weren't answered, both the ones that were sent in advance and the ones that came up in the question box today, and we'll see what we can get answered, and we'll continue the conversation via an email thread involving all of us, because this is really wonderful stuff. The last question I'm wondering if you can just touch upon is the last sentence of what Martin sent in at the bottom of the slide here is, how do you avoid the ghettoizing of the CAM practitioner in the hospital or other more conventional healthcare setting?
I didn't understand what he meant by that.
Possibly the segregation of CAM practitioners. Martin, if you want to quickly type something in, or Sean.
My assumption would be as seeing kind of as like ancillary or sort of an accessory service rather than of real value. That was my.
Yeah, why don't you go ahead and answer it as you understood it, and then if that's not what he meant, we'll find out via email.
Perfect. What I would say about this is largely, and I understand the sentiment, and I've seen this time and time again, especially when we juxtapose a CAM-based medical service against conventional or allopathic care, right? There is this hierarchical or patriarchal, really, sort of approach, whereas, you know, the big dog is conventional care, and then all these other services are like take it or leave it, right? And therefore is ghettoizing. That's my interpretation. So in this particular clinic, in this environment, to be honest, it's non-existent for me, and in part because I've done my sort of share to educate the other providers and the staff around the value of the services. Many of them have had the personal experience as well with acupuncture, Chinese medicine, you know, and the rest of it. So for me, it's a level playing field. We're all on the same page and viewed as physicians, both with the staff and together collectively as a group. So I don't get that hierarchical here in this setting, but again, largely because communication and also the experience that people have had with those services.
Yeah, I think when you're in a situation where you're sort of building your own integrative practice, this is maybe less of a concern. If we're placing people in a medical setting, so it's like already an existing medical setting that maybe not everyone is as open-minded as, or embraces integrative health, then I would say you need to outperform you need to silence your critics through your performance, but also keep on being visible and friendly, and spend your lunch hours going around and visiting all the different doctors and talking to them about patients, and reporting back in a very leaving not in an ego-driven kind of way, but just on a factual-based kind of way about the outcomes that you're getting, which also, coming back to outcome measures, why they're important to have, bringing them articles about things that they might want to see as far as research in your area for the conditions that you're talking to them about. But yeah, I think it takes a specific personality to really have the right balance where they're able to perform really well clinically, but also sort of toot their own horn, but not in a way that offends people.
And I would, the only other little tidbit quickly I'll add to that piece, Melissa, is being able to speak the language of other providers. For example, if you're like that, like, don't put it in Chinese medicine terms. That's just going to confuse.
Yes, don't tell them liver qi stagnation.
Right. Yeah, exactly. Like, put it in their language, and it's the same true for patients. Speak the patient's language just like you want to speak other providers' language, and so it takes competency and knowledge around other modalities for that reason.
Thank you both so much. I can't tell you how valuable this has been, and I can tell from the responses we're getting in the chat and the question boxes that people are really thrilled with the discussion that we had today. I thank you both for sharing your experiences and the time you put into preparing for this talk today. And I will have this recording edited and up on our website, and we'll be in communication about getting any other questions or comments answered and see what comes from that. So I thank you both very much, and thank you for everybody who's on the call today. And are there any other final words before I end this wonderful webinar?
I want to say thanks. This was fantastic. Really fantastic. I really appreciate that you packed so much into it in a limited amount of time. That was great.
Thank you, Marcia.
Thank you.
Yeah, big thank you to you both.
Thanks, Barry.
Thank you.
Thank you.
All right, everyone, we'll talk over email. Melissa, Sean, thank you again so very much for your time and your excellent presentations today. Much appreciated.
Thanks for having us.
Thank you.
All right. Bye-bye, everybody.